Hi, this is Julie Lubinsky. I am the Associate Director of Digital for the Christopher and Dana Reeve Foundation. I'd like to welcome you to Part 2 of the Pain Medication Education Series. It's being hosted by Jay Gupta. He's the Director of Pharmacy and Integrative Health at Harbor Homes in New Hampshire, as well as an MTM consultant and yoga therapist. I'm so excited to have him back for Part 2. Part 1 was very successful, and I wanted you to know that you can find the recordings on christopherreeve.org/pain. It's at the bottom of our pain article, as well as Part 2 and Part 3 will also be posted there. So now I want to turn it over to Jay. Hello, Jay.
Hello, Julie. Thank you so much. Hello, everyone. Thank you for joining this webinar and welcome. I see already a few questions popping up, so let's hold the questions towards the end of the webinar today. So today we're going to talk about opioids and addictions. Addictions are also known as opioid use disorder. So it's a very important topic, very, very dear to my own heart, because in my current role working for Harbor Homes, I work very closely with people who are undergoing the treatment for opioid use disorder. So just carry over the notes from the last presentation. As we all know, the way we think about pain and pain medication is rapidly changing. So if you're listening to this webinar afterwards on YouTube or Reeve Foundation website, just check for the updates on the information on all the 3 webinars. Also continue to work closely with your healthcare team and do your own research so you stay updated on the knowledge. Throughout this webinar series, I'm going to be using generic names of the medications. However, I'll mention some of the brand names which are commonly used in America to make it more relevant for you. I have no disclosures. I have no financial connection with many of the pharmaceutical manufacturers. Another disclosure I have is I have some images from the internet. They're not individually acknowledged, so I wanted to acknowledge that in the beginning of the presentation. So let's begin. So this is a 3-part health series about pain medications. First webinar, which we did on January 23rd, we talked about what is pain, types of pain caused by spinal cord injuries or disorders. We had a very comprehensive overview of all kinds of pain medications and how do we use them safely and some of the resources to stay updated on the medications. Today we're going to zero down only on opioids and opioid addiction or opioid use disorder. And in the next webinar in March, we will talk about how do we taper these opioids? What are the non-pharmacological options available? Many of you had asked questions about cannabis, cannabinoid oil, so we're going to discuss all those complementary and integrative therapies in the next webinar. So for today, we'll discuss what the opioids are, where do they come from, how do they work, why do they cause another disease when we're trying to help chronic pain. So why opioid use disorder happens and what can we do to minimize and save lives. So these are the objectives for today. Part 1, I'm going to just do a quick overview. We talked about 2 kinds of pain, nociceptive or inflammatory pain, as well as the neuropathic pain. So people with spinal cord injuries at the level of injury or below the level of injury usually get neuropathic pain. We went through this whole list of medications. Of course, you can go back on christopherreeve.org. There's a link in the bottom of this slide. You can see and you can read more about pain management as well as listen to these 3 webinars as well. I'll also request you to sign up for christopherreeve.org, their regular mailers, so you get more updated information about everything related to spinal cord injury with podcasts, webinars, blogs, forums. It's a really beautiful website, a lot of resources, and they're all free of charge. So let's talk about opioids. So the 3 terms you might have already heard. One is called narcotics, opiates, and opioids. Narcotics is kind of an obsolete term we don't use that anymore. Opiates are the natural substances which come from the poppy plant, from the poppy seeds. These natural substances called opioids, they bind with specific proteins in our brain in our spinal cord and also our digestive system in the gastrointestinal tract. Those are called opioid receptors, those proteins. So example of the natural substances would be morphine and codeine. Opioids, on the other hand, do the same job. They bind with the same receptors. The function is same, but they're either semi-synthetic or they're synthetic. So example of semi-synthetic would be hydrocodone and oxycodone. So that substrate, the raw material to make those hydrocodone and oxycodone comes from codeine, and completely synthetic made in factories would be examples would be fentanyl and methadone. DEA, which is Drug Enforcement Administration in America, part of Department of Justice, has 5 categories of controlled medications, controlled substances actually. Out of 5, the first category is illegal, so they are not considered medications. Other 4 categories are controlled substances which are used as controlled medications. And they are classified based on their risk of abuse or harm. So for example, category 2 medications will have higher risk of abuse and harm as compared to category 3, 4, or 5. Usually controlled substances or opioids, they are prescribed for moderate to severe pain. However, this is also shifting. In last couple of years, we have a lot of data to prove and say that this is not really recommended for moderate or severe pain either. The most common risk of opioids is the misuse, dependence, breathing emergency, which is caused by overdosing, and they can lead to death. The risk of opioids increases with higher doses and also with the long-term use. The 3 terms which I'm going to be using in this presentation repeatedly, one of them is tolerance, dependence, and opioid use disorder. So commonly we call addictions for opioid use disorder. So addiction has some stigma attached to it, but it's a disease, it's a chronic disease, so we prefer to call it OUD or opioid use disorder. Tolerance. What tolerance means is that you need higher dose of the medication to achieve the same effect over a period of time. So for example, if somebody is using morphine and you're taking 20 milligrams of dose today, over a period of few weeks or months, that person might need much higher dose of morphine to achieve the same pharmacological response. So that is what is called as tolerance. The dependence is when the body, the physically or mentally or psychologically, a person's become dependent on a particular medication. So opioids have a very common side effect of making the person dependent because it's replacing a natural opioid from inside, and when we don't get the dose on a regular basis, it can cause withdrawals. So we'll talk in detail about that in a few minutes. So these medications need to be slowly tapered off instead of just stop using them. As I mentioned, opioid use disorder or OUD is a chronic disease which is represented by uncontrollable cravings. Even if the person knows that it's going to hurt them, it's not really helping them, but people have no control over their medication use. So it's a compulsive drug use, and that needs treatment. Opioid use disorder, according to DSM-5, which is Diagnostic and Statistical Manual, which is most of the healthcare providers, the psychiatrists, will use this diagnostic criteria to see if somebody has opioid use disorder or not. So these are 11 symptoms here listed. If somebody has 6 or more symptoms, that person is classified to have severe opioid use disorder. If somebody has only 2 or 3 symptoms, it will be considered mild. So I wanted to just share this with you so you know that you or somebody you know might be falling into that category, and that person does need help. So how do the opioids work? They work in 2 major ways. I'm going to talk about the receptors in a few minutes, but what these opioids do, they attach to those opioid receptors, those proteins in our nervous system, in the brain, in the spinal cord, and they block the transmission of pain messages to the brain. So if somebody is experiencing a lot of pain, the message will not go to the brain, so thereby reducing the pain level. They also stimulate the pleasure centers in the brain. So it creates a feeling of pleasure, feeling good. We call it euphoria. And that is because of the endorphins being released. So endorphins, we'll talk about that as well. So they are the naturally produced neurotransmitters, the chemicals in our brain. And if we are constantly interfering with that natural production of endorphins, that can lead to addiction as well. So this is the definition of endorphins. So endorphins are morphine-like substances which originate from within the body. So I find it really cool to explain that body has natural opioids which are being released automatically in response to pain, or when we are feeling really, really good. And we feel good because of those neurotransmitters. The principal function, the main use of these endorphins is to stop those pain signals. So body has an innate capacity to stop those pain signals and make us feel good. Okay, so we'll talk about endogenous hormones, these endorphins, more in detail in the next webinar. There are 4 kinds of receptors. The mu-opioid receptors are the most commonly stimulated, so I don't want you to memorize these names. The reason I put the slide up here is so that you know that these receptors increase in number, or we can increase the number of molecules that bind to them to increase the analgesic, the painkiller effect, or to get the opioid high or feeling good. So how do we increase these receptors, and how do we get those molecules to bind more effectively to improve the pain management? We'll discuss that today and in the next webinar as well. I just listed all the products which are available for as opioid painkillers. So if you look at the whole list, somewhere in the middle here we see hydrocodone, and then we have oxycodone. These 2 are most commonly prescribed opioid painkillers in United States of America. Morphine, oxymorphone, so we'll talk about that very briefly, but these are all the opioids which work almost in the same way, just their potencies are different. There's one third from the bottom, propoxyphene. It was very commonly used until a few years back, but that has been taken off the market because it does produce the high. It makes you feel good, but it does not reduce the pain level for people. And then we have another category where we mix the opioids with antagonists. What that means is people have a propensity to abuse or misuse the medication. We add an antagonist so it cannot be misused. We'll talk a little bit more about that towards the end of this presentation. This is just a quick glimpse of a conversion guide from Centers for Disease Control and Prevention, CDC. So morphine is considered number 1, and other products are, their potency is gauged by how many units of morphine are required. Morphine equivalents are required. So for example, hydromorphone, if you see here, has morphine ratio of 4. So it's 4 times more potent than morphine. So if somebody is taking 20 milligrams of morphine and we need to switch them over to hydromorphone, they will possibly need only 5 milligrams of it. Just wanted to share that. Usually prescribers who are really treating the pain very well for somebody, they will switch over from one opioid to another opioid, and this is a conversion guide they usually follow. I'm going to go over some of the side effects of opioids. Drowsiness and dizziness is very, very common. Respiratory depression is something which is very, very serious. So when people die from the overdose of opioids, they mostly will die because of respiratory arrest. They are not breathing anymore. Constipation is very common, very uncomfortable side effect of opioids. And the reason I'm highlighting here is because our target audience today is people with spinal cord injury and their caregivers. So people with spinal cord injury already might have bowel movement issues. And by adding opioids in the therapy, we make that condition worse. Opioids also cause euphoria, the feeling of well-being, but they can also cause opposite of that, called dysphoria. It can lead to agitation. It can cause seizures, hallucinations. They lower the blood pressure. They lower the heart rate. They also can cause muscular rigidity and contractions. Again, that's one other reason why it is not recommended for people with spinal cord injuries. They can cause nausea and vomiting. They can cause itching in the body. Pupils in the eye, they get constricted. Sexual dysfunction. Urinary retention would be probably another reason why people with spinal cord injuries should not be using opioids. And as I mentioned a couple of minutes back, tolerance and dependence are very common side effects of opioids. How are they administered? Most commonly people receive by oral route, by mouth. It could be tablets or capsules. Some are slow release, some are immediate release. So depending on what formulation and what medication we use, they might take some time before they start working, but the effect lasts much longer as compared to other modalities like injections. So the next route of administration is intravenous. So IV will be the quickest route. So if somebody is suffering from pain, we give them intravenous injection, but they don't last for too long. The pain effect will come back as soon as the drug is weaned off in the system. Intramuscular is again in the injection. It has faster onset of peak analgesic effect for a little longer duration than IV administration. Epidural administration is when we inject morphine directly into the space. It's called epidural space around the spinal cord. So that's where the medicine is, absorbed slowly. So it has longer analgesic effect, which can last up to 24 or 48 hours. Transdermal patches, they are applied on the skin, and the drug is slowly released from the patch into the skin, and from the skin it goes into the bloodstream. So they are very slow release, but they last much longer time. So we recommend those medications for people with chronic pain to take care of the baseline pain level. So fentanyl patches are very common. They last up to 72 hours in the body. So they slowly release the medication for up to 3 days. There's another medication called Buprenorphine, which is Buprenorphine. That medicine is released slowly up to for 7 days. The biggest risk of transdermal patches is watching for heat exposure. So we have many cases where people, they go to the beach while wearing the patch, or they go to sauna, or they might live in an environment where the heat is high, not like New Hampshire where we have 20 degree Fahrenheit temperature. So if the temperature goes high, the medicine is released much faster from the patch. It goes into the bloodstream, so people will overdose and they might even die from the medicine. So watching for heat exposure is very important if you know somebody who is using transdermal patches for pain management. So this is the data from CDC website in America. If you see the trend for opioid prescribing, so it continued to rise from 2006 up to 2012, and from 2012 onwards it's on decline. As we understand the benefits and risks of opioids, it's shifting. This is another data from National Vital Statistics on mortality from the CDC. So there are 3 waves we had which increased the number of people who die from using opioids and when they overdose themselves. The first wave was in the late 90s because of the prescription opioids. So medications were given to people for pain management, but they started to kill people, and this is the purple line going upwards. And the second wave came in 2010 when people were starting to use street drugs like heroin, and that gave a rise in opioid deaths. And the third rise, which happened in 2013 because of the synthetic opioids, mostly it was fentanyl, which was mixed into heroin, into the street drugs. So you see a sudden rise in opioid deaths, and that's why this topic has become more relevant, more important for us to discuss today. So I thank you all for joining in so you can learn for yourself, but also people you know, and you can save their lives by understanding these products. If you look at the green line, the number of deaths caused in America over the last 17 years has continued to climb. The number of people who die from opioid deaths has become 6 times more than what we had in 1999, about 20 years back. So some more data. Opioids are very commonly used in America. They're not as common in other countries. So America accounts for only 5% of the world's population, but the residents account for 80% of prescription opioid use. So that's a huge proportion of opioid usage here. And it's not because people in America have more chronic pain. There are countries like France, Italy, and Ukraine where people report high rates of chronic pain. But in other countries, people use non-opioid medications and also non-pharmacological interventions, which we're going to talk about in third webinar next month. They're more commonly used or more commonly prescribed as compared to opioids. In the last bullet you will see here, there's a common myth. People who are using opioids, who are addicted to the medication, who have opioid use disorder, they get their medications from a drug dealer. They're buying them on the streets. So only 6% people actually get it from the street. More than 90% people got their opioids, the ones who misuse the opioids, they got them from a friend, a relative, or directly from the healthcare system through prescriptions. So some of the possible reasons, there was a recent study just 2 months back from JAMA, Journal of American Medical Association, where they examined that the marketing focus from the big pharmaceutical companies, where they focused on physicians, on about 400,000 physician-focused marketing payments were made. So the countries where pharmaceutical companies are able to market more aggressively to the physicians, that's where we see the greatest overprescribing. In late 90s, if you remember from the slide, which I just showed you, this one, there was a rise in wave 1 with the prescription opioid overdose deaths. So that possibly happened because Joint Commission campaigned to add pain as the 5th vital sign. So doctors will look at your vitals. There were 4 signs, but they said you have to aggressively now treat the pain as well. So that gave a huge bump to opioid prescriptions. Of course, it was stopped by American Medical Association in 2016. In 2009, American Geriatric Society, they came up with new guidelines, and they encouraged doctors to consider opioids for older adults with moderate to severe pain, that opioids are safer than long-term use of NSAIDs and COX-2 inhibitors. So those guidelines are also not in use anymore. But see, in the last 20 years, over a period of time, we have seen associations campaign, and they thought opioids were a good thing to use, but the knowledge is kind of changing. That paradigm is shifting right now. So most of the healthcare practitioners in America now are educated. They're mandated to be trained with the new guidelines, but more education is still needed. One of the surveys conducted by American Society for Anesthesiologists, just in January 2019, it was published, indicated that 2/3 of the parents believe opioids are the best option for their child after surgery or a broken bone. And parents did not ask about the safety and alternate treatments. They just asked for opioids. So I think a webinar like this will really help shifting that paradigm. So some of the newer data, so I'm going to talk briefly about the research. I don't want to give you a data dump, but this 4 published research indicates that opioids have small benefits on pain as compared to placebo. And they may outweigh, the benefits might be outweighed by the common adverse effects. So opioids are probably slightly better in pain management, but the risk is much higher. And 3 more studies indicated that treatment with long-term opioid therapy actually increases the pain. So it's associated with poor pain outcomes, greater functional impairment, and lower return to work rates. So more harm than the benefits. There was another study from veterans, so in VA primary care clinics. This was studied on 240 patients, and what they also found was that the study does not support starting people on opioid therapy for chronic back pain, hip pain, and knee pain caused by osteoarthritis. So let's switch gears here and talk about spinal cord injury a little bit. So as most of us might know, the spinal cord injury, after spinal cord injury, people might have pain which is not controlled by using everything we have in our tools, in our toolbox. So people might be using all kinds of painkillers and still the pain level is high. And because of that, what we found was people with spinal cord injuries are prescribed opioids for longer durations and at much higher doses than people with other kinds of chronic pain. So that has possibly caused more of the side effects like tolerance, dependence, and maybe opioid use disorder. So that's why we are talking about this today, that so many people are dying from overdose in America right now. I think what I remember, the last number I checked, about 130 Americans die every single day. And there are more people who die with opioid overdose than they die from a car accident in America. So we need to reverse that, and we'll talk about that. How do we change that? So this was a news from last year that use of opioids early in the treatment for spinal cord injury patients is found to make the pain worse in later part of their lives. So again, opioids not indicated for chronic pain after spinal cord injury. So there's some more reasons here. Multiple adverse effects, as we talked about, in spinal cord injury because of the respiratory function might be already compromised, particularly when the diaphragm is not really moving too well. We don't want to cause more respiratory depression by adding opioids. Bowel motility is another good reason, and hyperalgesia, which is an abnormally increased pain sensitivity because of opioids. So opioids might increase the sensitivity to pain instead of decreasing it. Risk of developing opioid use disorder, we talked about that, breathing emergency. However, one of the study from Bryce in 2017, what they say is if somebody's pain has responded without escalating the doses, then it's okay to use it for chronic pain, including neuropathic pain. But this is not typical. So very rarely some people might have their pain managed, pain in control with an opioid, but it's not very common. Most people, when they taper the opioids, they slowly wean themselves off, it improves their function, improves the quality of life, and it decreases the pain level as well. Kind of paradoxical to talk about painkillers reducing the pain when we take them off or taper them off. So now we'll talk briefly about the older adults as the population is aging. So people who have to use a wheelchair or people who are older in the community. So we don't think people who are older are misusing opioids. It's considered a disease for the younger adults. But in past 20 years, number of people who are hospitalized for opioid overuse, that number has become 5 times for older adults. The Medicare data revealed in 2016 that about 500,000 people in America were given opioids at a higher dose than the manufacturer recommended dose. The risks are similar to what we talked about spinal cord injury because older adults will have breathing complications. It will cause more confusion, delirium, cognitive decline, the memory loss, more drug interactions because as we get older, most people can have a tendency to take more medications. The biggest risk I would call is the increased risk of falls because after falls, most older adults will have very poor quality of life, particularly when it is associated with high likelihood of fractures. It can cause motor vehicle accidents, increased incidence of pneumonia, AFib, cardiovascular events, so not good for the heart. Of course, constipation, dizziness, nausea. So almost all the side effects we talked about of opioid use are not really compatible with what older adults experience as part of their aging process. Another big reason for older adults not using opioids is the pharmacokinetics, how these medications work in the body and what body does to these medications. So some of you might know this, but I'm going to quickly review this. When we take a medication, it has to be absorbed from the stomach, it gets distributed throughout the body, then it is metabolized as well. So for example, mostly medications are metabolized in the liver, and then they need to be eliminated. So kidneys play the major role in elimination of the medication. That's why we have to dose the medication every 6 hours, 8 hours, 24 hours, or 7 days, whatever the frequency of the medication is. So as we become older, these medications actually become more potent and they stay in the body for much longer time because the elimination function may not be good. The kidneys may not be functioning properly. The liver may not be functioning optimally. So the whole absorption, distribution, metabolism, and elimination is kind of out of whack. So when we do the studies on healthy individuals, we may not consider that doses need to be tweaked, might need to be lowered for older adults. All right, I'm getting a message out louder. I hope everybody can hear me. I'm going to be a little louder if I can. So now let us talk about discontinuing these opioids. How do we really stop these opioid use? So pharmacotherapy is the mainstream. We call it medication-assisted treatment programs. So we're going to talk briefly about that. It's not recommended that you suddenly stop taking opioids because of all the withdrawal and dependence which can happen with opioids. So there are two kinds of medications, agonist and antagonist. So we'll talk in detail. We want to suppress the opioid withdrawal symptoms. We want to reduce the cravings. And we want to also facilitate reduction and elimination of opioids by using the pharmacotherapy with agonist and antagonists. So let's look at MAT, the medication-assisted treatment program, which has become very popular in last, I would say, 5 or 6 years. Methadone is one of the oldest molecules which we have been using. It's called opioid agonist. What that means is it mimics the effect of opioids. It is an opioid. So it works exactly like other opioids will work on the receptor system. Buprenorphine is a newer molecule. It has been around for about 20 years or so. It is an opioid partial agonist. So that means it does not produce all the effects of an opioid, but partially it supports it. And third category is antagonist. So you want to block those receptors. So even if somebody takes an opioid, it will not have any effect. Okay. So methadone. So we have most evidence for methadone. For many, many years, methadone was the only option people had for opioid use disorder. People still go to methadone clinics every single day to get their daily dose. The biggest risk with methadone is that half-life of this medication is long and unpredictable. What that means is if somebody takes methadone, it might take 8 hours to become half in the body in the concentration, or it might take up to 59 hours. So that's why when we start people on methadone, the dose is to be individualized and titrated very, very slowly. So we start with the lowest possible dose and gradually increase until we get the desirable effect. Methadone usually blocks the withdrawal for over 24 hours. That's why it is dosed only once a day. There is also risk of respiratory depression and overdose, same as other opioids. And it is metabolized through some specific enzymes in the liver, and because of that, there are multiple drug interactions. And those interactions usually increase the risk of QT prolongation, means the rhythm of the heart is affected. So something like a common antibiotic, like a ciprofloxacin, for example, azithromycin, those antibiotics might have very strong interaction for people who are using methadone. So if you're using methadone, please do let your doctor and the pharmacist know about that so that they can monitor any potential harmful drug interactions. Of course, co-prescribing or using of any illicit medication, including benzodiazepines, can increase the risk of opioids. Methadone is also a Schedule II medication. That means it has high risk of dependence and tolerance and addiction. It changes the response to pain, so it can help with pain management. It mitigates the opioid withdrawal. It blocks the euphoric effect, so you don't feel the pleasant sensation or the euphoria which we get with other opioid painkillers. It's available in pill form, liquid form, vapor form, and the pain relief from the medicine lasts for up to 12 hours. The safety profile is almost the same, so calling 911 if somebody has overused it, definitely no alcohol, caution driving or operating machinery, watching for the breathing emergencies. That's the biggest thing you need to watch for. The second molecule we talked about is buprenorphine, which is a partial opioid agonist. It is a Schedule III medication, so it is safer than Schedule II medication, which is most of the narcotics, most of the opioid painkillers, and also methadone. So buprenorphine also works as a potent analgesic, so it's a painkiller. It has less of the reward system because it's partial stimulation of those receptors. Less of the respiratory depression, but overdose is still possible with this medication, particularly if somebody is using street drugs or in combination with benzodiazepines. Buprenorphine lasts in the body for up to 24 to 42 hours, so that's much longer half-life. So it will block the withdrawal. So most people, when they take buprenorphine, that medication is dosed every 24 hours. And as I mentioned, it is a good painkiller, so painkilling effect of buprenorphine lasts up to 6 to 8 hours. Now, this medication, buprenorphine, binds with the opioid receptors preferentially. So what that means is if it preferentially takes over those receptors, it can precipitate the withdrawal symptoms of other opioids. So what we recommend is weaning the opioids, giving a wait time of 12 to 24 hours before we start Suboxone or buprenorphine containing product. And it has less interactions, drug-drug interactions as compared to methadone. Buprenorphine is available in multiple brand names, and mostly because there's a potential for abuse, it comes in a combination product along with naloxone. So it cannot be injected, because if somebody injects buprenorphine and it contains naloxone with it, it will cause the withdrawal. So it kind of is a deterrent, so people do not misuse buprenorphine as well. So Suboxone is one of the very popular brand names. It's available as film and tablets. Tablets are actually generic now, so they are much more inexpensive as compared to all other brand names and the films. So watching for the safety, the biggest safety thing to watch for would be liver-related health issues. As you might know, hepatitis is very common in people who inject drugs. So it could be hepatitis B or C. Liver function might be compromised. So doctor would actually monitor you or the person who is using buprenorphine for liver function. It is not really recommended for pregnant people, but Suboxone is not recommended as compared to buprenorphine. So it's category C. We have 5 categories of medications for pregnancy. A, B are considered safer than C, D, and X. So X category is never recommended for people who are pregnant. C and D have higher risks. Just wanted to share that knowledge, that information. So for prescribers to be able to prescribe buprenorphine as a medication-assisted treatment program, they need specialized training. They need a CSAT waiver. So a lot of providers are nowadays doing it. Initially, it started with some doctors, but now nurse practitioners are also allowed to get the training. Their training is a little longer, and they can also start prescribing buprenorphine. And it's not just the whole treatment. Mostly when people are put on a MAT program. They also need psychosocial support. So we have psychotherapy, intensive outpatient program, partial hospitalization programs. All these supportive programs also help in recovery of the patient, while the medicines are also helping them. So some of the outcomes which were published in 2014, so people who are not using medication-assisted treatment program, more than 90% people relapse within a few months. So people are able to quit cold turkey, but they need some extra support. And they found people who are using opioid agonist therapy, means you are using either methadone or buprenorphine, about 66% people continued in the treatment. So it creates a culture of recovery, less deaths, less criminal involvement, and less healthcare emergencies. And what they found was there was increased number of people who got their jobs into the gainful employments. Opioid agonist therapy, as I mentioned, the treatment has increased. One of the new things which we notice is happening, I think it started somewhere in New York, that emergency room physicians, when they see a person after overdose, they start providing Suboxone or buprenorphine therapy right in emergency room. So this is kind of a new thing. We are still watching. Is it how successful it is, and are we able to put people on medication-assisted treatment program so they can come back in recovery and start to stop using street drugs. There are a couple of myths about it. One of the myths is we are trading one addiction for another, which is kind of true in case of methadone, that people are physically becoming dependent on one drug like methadone or buprenorphine instead of being dependent on heroin. The reason we still recommend these treatments is because there are a lot of other effects of street drugs or other opioids which we don't have with MAT drugs, methadone and buprenorphine. Another myth is these drugs are as dangerous as heroin. That is not true. The biggest reason why people have lost lives and they still continue to lose lives is because heroin coming from the street does not have any quality assurance. In the last couple of years, we found that heroin was contaminated with fentanyl or carfentanil, which is more potent. So people were using their regular dose of heroin, but overdosing themselves, getting into breathing arrest, and dying on the streets. So that's really sad. And I work in Nashua, New Hampshire, where we have probably in the whole country the highest number of deaths. January 2019 was the first month in many years where we did not have any fatality. Nobody died in the whole month of January. But there's a lot of work which involved the city of Nashua. We created a safe station program, so we'll talk about that some other time. But I just wanted to give that out there, that it's better to be in recovery from opioids than continue using opioids. All right, let's talk about antagonists. So antagonists actually block the receptors of opioids. That means if somebody takes an opioid, or whether it is exogenous opioid from outside or endogenous endorphin, which we call endorphins, for pain management or for pleasure, it will just block that action completely. So there are two molecules here which are very similar in chemical structure. One is called naloxone, other one is called naltrexone. Naloxone is short-acting and it acts very fast. So when people overdose from opioid, this molecule is actually a lifesaver. So we'll talk about that in a few minutes. Naltrexone, on the other hand, lasts much longer in the body and it acts slowly. It blocks the cravings for both opioids as well as the alcohol. And the effect will last for almost 24 hours or maybe more. There's a long-acting injectable available, it's naltrexone injection under the brand name called Vivitrol. The effect lasts for up to 4 weeks. So people get that injection every 4 weeks, drastically reduces the cravings. Naloxone. So for opioid overdose, it blocks the receptors, reverses the toxic effects. It's available, very commonly used as an injection, but also as intranasal spray. Naltrexone is not a controlled medication, so it's safer. People do not get addicted to naltrexone, but patient must be opioid abstinent for at least a week. If people have not stopped using opioids for at least a week, their receptors have not been clean, the person will get into the withdrawals. So we'll talk about withdrawal symptoms in a few minutes, but it's not recommended for people who are actively using any of the opioids. So clinically, as I mentioned, it can be used for every 24 hours or maybe every 3 days. Injection is used every 4 weeks, suppresses the cravings, can be used for alcohol as well as opioids. It should not be used with alcohol and sedatives and tranquilizers, and it has some advantages over agonists, but also some disadvantages. So CDC guidelines. So what the CDC guidelines are acknowledging that pain is complex, but evidence for long-term opioid efficacy is very limited. So we need to limit the use of opioids as much as possible, deprescribe opioids, taper them off, and using non-opioid painkillers and non-pharmacological therapies is recommended. So signs of opioid overdose. People, as I mentioned before a couple of times, they die because of breathing arrest. The lungs will stop working. But symptoms, common symptoms, the face is pale, clammy to touch, body becomes limp, there's a purple or blue color in fingernails or lips, vomiting or making gurgling sounds, and person cannot be awakened from sleep or is unable to speak at all. For prevention, what we recommend is naloxone. U.S. Surgeon General in 2018 urged Americans to carry a product called Narcan, which is a nasal spray which can save lives for people if they're overdosing or they have overdosed themselves. So this is how it looks like. A lot of free programs out there which will give you a free sample of that. Many insurances will cover. Most pharmacies have a standing order. That means they do not need a prescription for naloxone. And you can read more about that from this website, narcan.com. So just a reminder about spinal cord injuries. Most people will have neuropathic pain, and for neuropathic pain, the first-line therapies are pregabalin, gabapentin, and amitriptyline. We talked about that in detail in webinar number 1, and the second-line therapies are tramadol and lamotrigine. Controlled medications, the opioids, are not recommended here. So last but not the least, I would invite you all to stay connected with the Reeve Foundation through christopherreeve.org, signing up for their newsletter, becoming an advocate. Christopher Reeve Foundation does a lot of advocacy work, so connecting with them, becoming an advocate. You also have an opportunity until April 1st for next 40 days or so. You can go to Health and Human Services website, hhs.gov, and you can share your views about best practices for pain management. So they have it open now for everybody who can go in there and share, so we can bridge the gaps in the treatment, because we know many people who were using opioids, for them providers might have stopped giving them opioid painkillers suddenly, or might be weaned off much quicker than their bodies were required to do. So these are some of the opportunities where you can also make a difference for not only your life, but just overall guidelines for pain management. So just to summarize what we just talked about, and I shared most of it in the first webinar as well, to know your medicine, know your physician, and know your pharmacist. So when you're under treatment, make sure you share all the medications you take with physician as well as the pharmacist, including over-the-counter products. So some people take vitamins or over-the-counter herbal products which might interact with their medicine. So very important to share that information. Reporting any new pain or intensified pain. That could be because of the medication, or it could be because of a newer condition. Knowing your medicine, so staying updated on the warnings and the knowledge base about the medicine. It shifts, changes all the time. Also, using the medication as they are prescribed for you. So if you need to take more medication or it's not working well for you, reviewing it with your doctor, reviewing it with your pharmacist on a regular basis. Storing and disposing of the medicines appropriately. We talked in detail about that in first webinar as well. Now, if you're using opioids right now, please do not stop taking them suddenly. So they need to be tapered off slowly. Understanding the signs of breathing emergency and having an emergency plan in place, for example, having naloxone on hand. Also, never mixing any of the pain medications with alcohol, sleeping pills, or any of the street drugs, because that can be very dangerous. And as I mentioned, becoming an advocate or becoming a peer mentor or finding a peer mentor from the Reeve Foundation website. So going to christopherreeve.org and getting just connected with real people who are experiencing pain and sharing your experience with them and their experience with you. And we'll talk about integrative health in the part 3 of this webinar, where we'll talk about cannabinoids. I had a lot of questions last webinar, and even today I'm seeing some of the questions. People are asking about marijuana and cannabinoids, so we'll discuss those, and as well as integrative health therapies or non-pharmacological interventions. So I look forward to seeing you all next month again. And we have a few more minutes. I would love to get your questions, share my answers with you. So we have a chat box. Please post your questions there. I see only 2 questions here. So the first question is, post-acute injury, what is the rate or percentage of people with spinal cord injury prescribed opioids at any point? I don't have the data, I don't have the numbers, but I would assume it was very high. Those studies which are mentioning that people who were given morphine right after the injury, their pain management was very poor after a few months or years. Those studies are much newer. So, but I don't think we have published data. If I have your email ID, I can research it. I would love to share that with you if I find. So please email me and I'll get back to you if I find any data on that. Why are older adults seemingly exempt from OUD? That's another question. I did not mean to say that older adults are exempt. Most people consider misusing opioids as a younger people's disease. That's what the general impression is. Most people who are actually dying with opioid deaths, as I mentioned, about 130 people die every day. Majority of those folks are actually much younger than 40 years of age. So the next question is, do people ever not have to take methadone, or is it needed for lifetime? Is this true for other agonists as well? So that's a great question, and my understanding is the way these medications were designed were like a crutch, that you take the crutch if you're not able to walk on your feet, so this will support your recovery, and over a period of time you might be able to taper off that particular medication. However, in my current practice, where I work as a director of pharmacy for a nonprofit, where we help homeless population, a lot of people in recovery, what we find is this crutch can extend for much longer time than we anticipated. So yes, I have seen people getting into recovery and gradually weaning themselves off the opioid agonists, but majority of the people unfortunately continue taking these medications for much longer duration of time. Next question is, does the data show which states have the most abuse for these medications? As far as I remember, we have Ohio, West Virginia and New Hampshire, where we noticed maximum number of deaths with opioids. So West Virginia, I think, is number 1, and New Hampshire might be number 2 or 3. This is where I work in the city of Nashua, where we had very high percentage of people dying from opioid overdoses. The next question is, do I know the overdose rates in spinal cord injury patients for Rx opioids, both fatal as well as non-fatal? I'm sorry, I do not know specifically for spinal cord injuries. We know it is high usage of opioids with people with spinal cord injury, but we don't have data on that as far as I have been doing this research. Another great question. Why do you think, in your experience, people can get rid of crutch? Is it social reasons, family support? My answer would be yes, all of it. So people who have more hope, people who have a good support system, not from just the family. Some people we work with may not have family support, but even if it is a community support, those people have higher chances of recovery and staying in recovery for much longer time. People are becoming CRSW, so they are community resource support workers. They are supporting other people in recovery. They're getting jobs. They're getting families. So that I'm seeing as a trend, which is really beautiful. From the social perspective, from the community perspective, we are noticing that it takes a whole village for people in recovery to support. So in Nashua, we created a very special program called Safe Stations program, where people, after overdose, if they know they have used adulterated heroin, which is tainted with fentanyl or carfentanil, they could go to any fire station. Fire personnel are trained to call our agency, or they call emergency room, so that we can save the lives of people who have overdosed themselves. So yes, support system is very, very important, and we are still struggling with this epidemic level of deaths caused by opioids. The next question is, you talked about people with spinal cord injuries. Do I know of any data on people with traumatic brain injuries? So I'm sorry, I have not studied traumatic brain injuries, so I do not have data on that. So in general, I would say wherever there is a chronic pain, people would be given a lot of options for pain management, and opioid used to be very commonly prescribed until about 4 or 5 years back. Okay, so it seems we are out of questions. If you have more questions, you're welcome to go to Christopher Reeve YouTube page, where this webinar will be posted, and I would love to take some more questions there and answer as we go forward. So I don't know if I'm still connected or not. I'm getting a warning here. I don't know, because of the time. I see a raised hand. So I'm assuming everybody is able to hear me. I'm going to take one more question. I do not understand Schedule 4, 3, and 2 drugs. So what that really means is, coming from DEA, Drug Enforcement Agency administration, is that drugs which have high potential for misuse are considered Schedule 2, and Schedule 3, 4, and 5 have much lesser risk, and they're scheduled because they have high potential for misuse. All right, everybody. Thank you so much, and I look forward to stay connected and answer more questions through the video posted on YouTube channel of Christopher Reeve Foundation. Thank you.